So we just give a few minutes for the numbers to climb and for everyone to join in.
Okay.
Slowly climbing. Okay. Gonna give it a few minutes, okay? Okay. Thank you, Mozn, for making yourself available tonight. I really appreciate it. I know it's a lot of work that goes into a presentation like this, and I think everyone will agree after tonight that you really did a very good job, really.
Thanks a lot. No, it's my pleasure.
Okay, I think the numbers are steadily climbing. So what I'm going to do is I'm just going to go through the formalities. First of all, good evening, everyone. I'm Dr. Suzette Stander, and I will be representing tonight the South African Society of Periodontology, Implantology, and Oral Medicine, as well as SADA, as part of Oral Health Month's webinar series. And we are very, very lucky to be joined tonight by our guest speaker, Dr. Mozn Abdalla. Thank you, Dr. Abdalla, for availing your time to come and share this interesting case with us tonight. We're really all looking forward to it. Just before we get into the nitty-gritty, let's just go over some announcements that's important for us before we start with tonight's webinar. So, dear colleagues, please refrain from using a raised hand. Type your comments and questions in the Q&A section on the tab, the Q&A tab at the bottom of your screen. There will be CPD certificates, which will be loaded on the SADA platform, and you will be able to access all your certificates under your member profile. If you're not a SADA member, you will be able to create a profile for yourself and access your CPD certificates there. The event for tonight carries the equivalent of 1 CPD. And we are streaming live tonight on YouTube as well. So in case you have difficulty to access the Zoom platform, you can log into or watch via the YouTube channel as well. Then I just would like to remind everyone to complete the evaluation after the webinar, please. And then upcoming webinars, important to diarize. On the 16th of September, we have Dr. Gavin James, who will be representing biotensegrity and the ortho T&D link. And on the 21st of September, we will be hosting Dr. Leanda Kotze, who will be, whose topic is herpes simplex virus versus recurrent acute stomatitis. So we really look forward to those 2 upcoming seminars and webinars as well. Okay, so I would like to just introduce Dr. Abdalla to everyone. I know her from the university, and I'm very privileged tonight to be able to introduce her to you all. Dr. Mozn Abdalla graduated from the University of Khartoum in 2007 with a degree, the bachelor's degree in dental surgery. And in 2010, she registered at the National Board of Dental Examination of Canada and cleared the Canadian board examinations, the assessment of fundamental knowledge in 2013 and the assessment of clinical judgment in 2014. She received the basic dental training at the Dental Simulation Training Center in Ontario in 2015, and then she volunteered in a multicultural community dental center in Ontario, Canada, over the period of 2016 to 2018. And in 2018, she decided to move to South Africa and to start her Master's of Science degree in periodontology, and she graduated in December 2020. And in January, as if that wasn't enough, she started the course here as a MChD registrar in periodontology and oral medicine at the University of the Western Cape. And we're all very privileged to have her tonight to represent a very interesting case of squamous cell carcinoma in patients with ulcerative colitis. Thank you, Dr. Abdalla. I'm going to give the floor to you now, and afterwards we'll look at some questions.
Thank you, Dr. Stander, for the warm welcoming. And thank you, everyone, for being here and for allowing me to share my case with you this evening. So I'm just going to start by sharing my case. So this evening, I'm sharing a case of a squamous cell carcinoma in a patient with ulcerative colitis. So my patient is a 38 years old male who walked into our clinic at Tigerbread Dental Hospital complaining of an ulcer on the lateral border of the tongue. The ulcer was chronic and was present for more than 3 months. The patient was aware of the ulcer, which started as a blister, and then with time, the ulcer started to enlarge and grow and became more painful with time. Patient was using an over-the-counter topical anesthetic gel just to help him numb the pain. As for the medical history, the patient was diagnosed with ulcerative colitis in 2013. He is the father of 2, married for 20 years to his high school sweetheart, and he's currently unemployed. The patient reports no allergies or no history of hospitalization, and he indicates that diabetes is a disease that runs in his family. Regarding risk factors, the patient had never smoked, and he consumes alcohol only occasionally. In his own words, 1 glass every 2 to 3 months. And the medication that is consumed by the patient is adaceprine 50 milligram twice a day for 8 years since he was diagnosed back in 2013. And adaceprine is a medication that is used for management and treatment of inflammatory bowel diseases. And this term is given for two conditions, ulcerative colitis and Crohn's disease. Adaceprine is basically an immunosuppressive medication that acts by inhibiting purine synthesis. And purines are needed for DNA and RNA production. So when it inhibits purines, there is not enough DNA and RNA for lymphocytes, which this is how it causes the immunosuppressive effect of the medication. The other medication the patient is using is Dynaxine ointment, 10 milligram. And in each 10 milligram, there is 50 milligram tetracaine HCl anesthetic agent. So the patient was using it 4 times a day, and he'd been using it for 2 months. This is an over-the-counter ointment. So in the extraoral examination, the face was symmetrical, Jackal was clear, and the TMJ was normal. And in the intraoral examination, everything was normal and we had a free tongue movement. This is an important sign for us because the tongue is mainly composed of muscles and there is no anatomic boundaries to prevent the spread of tumor. So when tumors are spread from the tongue, they usually cause fixation and limited movement of the tongue. So the fact that our patient have a free tongue movement is actually a good sign. So in the intraoral examination, this is a clinical picture of that lesion. So the first lesion we have is a large, deep ulcer that is 20 times 20 millimeters on the lateral border of the tongue. The ulcer was extending from area of tooth 4-1 to tooth 4-4. It had a rolled raised margin, raw erythematous middle, necrotic center, and it was surrounded by a white halo. A second lesion was a small erosive lesion that is measured 2 times 2. 2 is for length and 2 is width. So it measured 2 times 2 millimeter and it was 3 millimeter away from the main ulcer. Posterior to that lesion, there was a zone of erythroleukoplakia, which also measured 3 times 2 millimeter. And inferior, close to the floor of the mouth, opposite to tooth number 3-6, there was a 6 times 7 millimeter non-homogeneous, irregular surface, corrugated surface, leukoplakia-like lesion. It was posterior and inferior to the main ulcer. So looking at the clinical picture that we have, we need to come up with a list of differential diagnosis for the causative factor that might have caused such a lesion. And when we look at the location, the duration, the presence of pain, the presence of the erythroleukoplakia, even the shape of the ulcer with the rolled margin. So the first thing that will come to our mind is a neoplastic origin. And in the neoplastic origin, we're going to consider squamous cell carcinoma as our main causative factor in the differential diagnosis. So other factors that could cause a similar lesion, we should consider an infective origin. And in the infective category, we're mainly considering TB ulcer. So TB ulcers are not very common intraorally, but it can occur. And when it occurs intraorally, it can be primary, which is associated with cervical lymphadenopathy, or it can be secondary, which is associated with pulmonary manifestation. The TB ulcer, when present clinically, it appears as irregular, pale with indolent margin, and sometimes necrotic sloughing of the base of the ulcer can be present. Another source that should be considered is Treponema pallidum and syphilitic ulcer. And what characterizes the important characteristic of the syphilitic ulcer is that when it occurs intraorally, there is absence of pain. But when we have the oral chancre, it can appear as self-limiting and specific ulcer, mostly affecting the lips, the commissure, and the tongue. Cytomegalovirus-associated ulcers should also be considered, and oral lesions resulting from cytomegalovirus have been mainly reported in HIV patients and chronic immunosuppressive population. And the fact that our patients have been using the immunosuppressive medication for 8 years make us also consider cytomegalovirus as a differential diagnosis. Let's not forget about the HIV-associated oral ulceration and the major ulcers that is caused by HIV, and deep fungal ulcerations caused by histoplasmosis, blastomycosis, and mucormycosis. All these are considered because of the fact that our patient is taking immunosuppressive medication for 8 years. So in the reactive category, there is also the main differential diagnosis that we should consider in the reactive category is the eosinophilic ulcer, TUGSI. TUGSI is a traumatic ulcerative granuloma with the stromal eosinophilia. So this is a rare, benign, self-limiting reactive lesion. The main mechanism is not completely understood, but trauma plays a major role in the initiation of TUGSI. And because it's chronic and it resembles, it can mimic malignancy, the shape of the ulcer and the chronicity of the lesion that occur with TUGSI can appear clinically very similar to carcinoma. And the only way to differentiate is histologically, where we're going to find the dense inflammatory infiltrate in the eosinophilic ulcers and the eosinophilia. So the last category we should consider is the autoimmune disease, which is the oral manifestation of the GIT disorder, ulcerative colitis, that the patient already have. So in ulcerative colitis and GIT disorders, oral manifestations can occur before, during, or even after resolution of the disease. And it usually appears clinically as a linear persistent ulcer. And histologically, it can be differentiated because the presence of the non-caseous granuloma and lymphocytes, epithelioid cells, and giant cells. So diagnosing oral ulcers might be quite challenging. And this article by Mortazavi et al. In 2016 aims to introduce a decision tree for diagnosing the oral ulcerations. They looked into two characteristics: the duration of the ulcer, which can be acute, chronic, or recurrent, and the number of the ulcers, which can be solitary or multiple. So for example, if our ulcer is acute ulcer and it was only solitary, then traumatic ulcer necrotizing sialometaplasia should be considered as a differential diagnosis. If our ulcer is multiple ulcers, then herpes simplex virus infection should be considered, like the primary herpetic gingival stomatitis, varicella zoster virus, herbangina, hand, foot, and mouth, erythema multiforme, necrotizing gingivitis, oral hypersensitivity reactions, plasma stomatitis, and chemotherapy-associated ulcer. Now, let's look what if our ulcer is chronic, and if it was chronic and solitary. So this is the category where our squamous cell carcinoma falls into, and the differential diagnosis is the same like we discussed in the previous slide. If it was chronic multiple ulcers, then vesiculobullous lesions should be investigated. Recurrent ulcers can be solitary or multiple, and for recurrent ulcers, recurrent others and recurrent herpes stomatitis should be investigated, herpes-associated erythema multiforme, cyclic neutropenia, and Behçet disease. So now let's look, so that was the differential diagnosis for the main ulcer that the patient presented with. But there was also other lesion, which is the white lesions that was present. The first lesion was the white lesion with red lesion that does not rub off, and then shows that it was an erythroleukoplakia as a differential diagnosis. And the lesion that we said that had irregular border and non-homogeneous and opposite to 3-6, this differential diagnosis for that lesion is basically leukoplakia, proliferative verrucous leukoplakia, verrucous carcinoma, squamous cell carcinoma, or even chronic hyperplastic candidiasis and mucocutaneous candidiasis. So from the same author, Mortazavi et al. In 2019, he came up also with the decision tree for the white lesions. And our lesion is an acquired that does not scraped off and without a specific pattern, and mainly it falls into this category, as we mentioned earlier, where we have the proliferative verrucous leukoplakia, oral leukoplakia, oral hair leukoplakia, squamous cell carcinoma, verrucous carcinoma, and candidal leukoplakia as the differential diagnosis. If it was benign, then also frictional keratosis and nicotinic stomatitis, if the patient was a smoker, all of these should be considered. Then selection of the biopsy site. So a suspicious oral lesion, particularly a large one like this, can vary in disease severity from one area to another. So for example, an area might show an invasive squamous cell carcinoma, while other area may show mild to moderate dysplasia. And actually this was our case. This is our results, where this area over here of the ulcer have shown an early invasive squamous cell carcinoma, while the erythroleukoplakia have shown mild to moderate dysplasia. So what is important in such a case is taking multiple biopsies from different parts of the lesion, particularly if the lesion is so extensive or it shows a variety of clinical presentation, like an advanced ulcer, while areas with erythroleukoplakia. So multiple biopsies will ensure that we have a viable and reliable biopsy results. Another thing we should also consider is that an appropriate biopsy should include tissue from the worst part of the lesion, and the worst part can be judged clinically. So in our case, this is the invasive squamous cell carcinoma over here. The ulcer area is the worst looking part of the lesion, and we should avoid biopsying the center of an ulcer, because when the tumor grows, usually the middle part is away from the blood supply, and this will result in deprivation of the nutrients, and the area will become necrotic. So there is no point of biopsying the middle of the ulcer, which is going to be only necrosis. So also including areas of erythroleukoplakia or non-homogeneous leukoplakia can also result in most dysplastic tissues. So those should also be included in the biopsy. So what we could have used to help us decide also where to biopsy is the use of adjunctive tools such as toluidine blue and viloscope. So toluidine blue is used to stain tissue that have high nucleic acid. And because this plastic cell have higher mitosis and higher content of nucleic acid, the dye uptake is more by these cells, it's easier for the dye to penetrate into these cells, which appears clinically and is very distinguishable clinically, where the tissue appears dark blue, like you can see in this picture. So this will guide us to where we biopsy. Another thing we could have used is the viloscope, which is a device that is used to examine the oral mucosa. It emits light, and when the light reaches the oral mucosa, it activates endogenous autofluorescent substances called fluorophores. So this will result in reflection of light with different colors, where the pathological mucosa will appear darker than the normal mucosa, which will appear green. Okay. So 2 sites were selected for our biopsy to achieve a full representation of the condition. In the first site, an elliptical incision with a length to width ratio of 3 to 2 millimeter. It included the elliptical shape. It was done basically just to facilitate the primary closure of the wound. The second site is the erythroleukoplakia site, and an elliptical incision of the erythroleukoplakia was done. And when we remove the biopsy, we try to include some of the normal tissue within our biopsy. And this is basically to help the pathologist to compare between the normal mucosa and the dysplastic one. So we avoided taking a biopsy of the leukoplakia-like lesion over here because of its proximity to the lingual artery. So looking to some anatomy, looking to the lingual artery course, if we look at the position of the lesion, it's very close to the course of the artery. And the lingual artery, which is a branch of the external carotid artery, is the principal artery that supply the tongue, the mucosa and the gingiva and mucosa floor of the mouth and the sublingual gland. And within the tongue, the lingual artery is lying deep into the hypoglossus muscle. So it gives up 4 branches. 3 of these branches are given within the tongue. And these branches anastomose to ensure a rich blood supply to the tongue and the vital structure at the floor of the mouth. So another alternative we could have done, because we avoided the biopsy, we could have used brush cytology as a non-invasive diagnostic technique, where we use a specific oral brush to extract cells from all the transepithelial layer as well as the emerging basal layer. So basically, when we're using this brush, we know that our epithelium does not have a blood supply. So we want to scrape all the epithelial layer. So we want to leave behind a bleeding surface. This will tell us that we have removed all the epithelium. So to provide the pathologist with all the epithelial layer included in our brush biopsy. So a biopsy was done and absorbable 5-0 polyglycolic acid sutures were used to close the wound by primary intention. Single interrupted sutures and horizontal matrix sutures were applied. And our results came back as results from site 1 as moderately to well-differentiated invasive squamous cell carcinoma with perineural invasion. We're going to discuss later what is perineural invasion. And biopsy site 2 have shown mild to moderate dysplasia. There is no lymph tissue involvement in the sample, and the patient was referred to the ENT clinic at Tygerberg Dental Hospital. So a special investigation that was done is a P16 immunohistochemistry, and the P16 is a cell regulatory protein that is usually overexpressed in dysplasia associated with HPV infection. So the P16 immunohistochemistry has become the recommended standalone prognostic test for patients with oropharyngeal squamous cell carcinoma, especially in South Africa, because it is cost-effective and it's less technically complicated than the HPV specific test like the PCR and in situ hybridization. So this finding suggests that our lesion is not associated with HPV. So in the literature review, we're going to look into carcinogenesis and the hallmark of cancer. And carcinogenesis is basically a multi-step process in which our normal epithelial cells or our normal cells acquire some characteristics that help them to transform into dysplastic cells and help them form tumors. So these characteristics have been classified by Hanahan and Weinberg in 2011 and known as hallmark of cancer. So one of these characteristics is sustaining proliferative signaling. So tumor cells have the ability to release their own growth factors. They also have the ability to increase the surface receptor for growth factors. This is what will result in their ability to proliferate and sustain their signaling. Another characteristic these cells acquire is evading the growth suppressors. And by growth suppressor, we're basically talking about 2 important tumor suppressor genes, the retinoblastoma and the P53, which is known as the guardian of genome. These genes work basically at the checkpoints at the cell cycle. So they're basically like the policeman who stop the cell cycle to check for the integrity of the genome and make sure there is no DNA mutation. If the cell is and if they find DNA mutation, then they activate the DNA repair mechanisms. And worst case scenario, if the DNA is not repaired, then the cell is sent to commit suicide, which is the apoptosis, the programmed cell death. So the ability of the tumor cell to escape those genes means that even if the tumor cell have mutation, it's still able to proliferate and grow. And this is what gives our tumors ability to enlarge and grow even more. So another also important characteristic, this cell gain, is evading the immune destruction. And we all know the role of immunity in protecting our body against pathogens, but this is not the only role of immunity. Immunity also plays a very important role in protecting our body against tumors. And this has been actually even proven more where there is increase of malignancies in patients who are immunosuppressed. So when the cells are able to escape the immune surveillance, they're able to proliferate and grow even more. After that, also one of the most important characteristics is enabling replicative mortality. And they do that by producing an enzyme that is called telomerase. What does it do? Do you know how your shoelace at the end have two plastic parts to protect it? So the chromosomes at the end have something called polymers. So these polymers function to protect the integrity of the genome. And every time when the cell divides, it loses some of these polymers and it shortens until it gets to a point where the cell cannot divide anymore. And this is aging peacefully. So what the tumor cells have the ability to do is basically produce the enzyme that's called telomerase, which have the ability to regenerate the polymers, which means the cell is able to divide unlimited divisions. And actually, this will result in accumulation of the DNA damage and increase the chances of DNA damage and mutations. After that, then also the tumor promoting inflammation, where it creates this environment that is full and rich in cytokines and pro-inflammatory mediators, growth factors that the tumor need to grow and proliferate. And if mutation is the spark that started our fire, it started the carcinogenesis, then inflammation is the fuel that feed it and make it grow. So now at this point, our tumors formed. So what does it need? It actually needs its own nutrients and blood supply. And tumor cells, they have the ability to induce angiogenesis and form their own blood vessels by releasing growth factors like tissue growth factor B and vascular endothelial growth factor, which help these tumors to form their own blood supply. Then genetic, epigenetic, and environmental factors resulting in genomic instability, and these cells have the ability to resist apoptosis and reprogram energy metabolism in what is known as Warburg effect, where they do aerobic glycolysis and where the cells get the molecules and organelles it needs. After that, our tumor is now ready to invade and metastasize. So the oral cavity is one of the most predominant sites for the development of potential malignancies, since it comes into direct contact with many carcinogens. So the squamous cell carcinoma is one of the most common malignancies developed in the oral cavity with a survival rate of 5 years. Multiple risk factors are associated with squamous cell carcinoma is tobacco smoking, Ericanet and betel quid, alcohol, and some people tend to drink and smoke at the same time. This is even more dangerous because it potentiates the carcinogen, where alcohol acts as a solvent for the carcinogens in cigarettes, and cigarettes can help form acetaldehyde out of alcohol, which causes DNA mutation. HPV, where the malignant strains P16 and P18 have the ability to cause oropharyngeal carcinoma, been associated with oropharyngeal carcinoma, which have better prognosis than the non-HPV associated. Diet, where where it's been proved that diet that is rich in antioxidants have a protective role against cancer and genetic susceptibility. So an important concept for us to understand is the oral field cancerization. And this concept was introduced by Slater et al., who found histologically altered tissue surrounding the squamous cell carcinoma. This concept is used to explain the recurrence of tumors and the presence of multiple tumors, variable tumors at the same time. So the oral field cancerization indicates that oral cancer does not arise as an isolated cellular phenomenon, but rather it's an anaplastic tendency involving many cells at the same time. So once all of that will result in cancer at different stages in the various field as a response to a carcinogen. And this is, again, emphasizes on the importance of multiple biopsies. And actually, the oral field cancerization speaks directly to our case, where we have the lesion of the squamous cell carcinoma, the ulcer, and then we have the white lesions that show dysplasia. So this is the squamous cell carcinoma at variable stages of the disease. Again, important to take multiple biopsies to have a full representation. So oral field cancerization has been estimated that around 5 genetic mutations are required for a normal epithelial cells to transform into this plastic cell. Loss of chromosomal material in 3q, 9p and 11, 3p, 9p, and 11p are associated with the early stages of the disease, mild dysplasia, and loss of chromosomal material in 4q, 11q, 13q, and 8p are associated with the advanced stages of the disease. So the prognostic factors for squamous cell carcinoma. The first prognostic factor is staging and grading. In staging, we have the T and M system. That T speaks to the size, N speaks to the lymph node involvement, and M speaks to the presence of metastasis. And we also have the grading that looks into how different the cell look under the microscope from the normal cells, where the poorly differentiated have the poor prognosis and the well-differentiated have the better prognosis. The tumor thickness, which is measured as the distance from the highest point of the tumor to the deepest infiltrative part of the tumor, and increasing the tumor thickness is associated with the poorer prognosis. The margin status, remember when we said when we took a biopsy, we remove some of the normal tissue to help the pathology to compare. So if within that normal tissue, dysplastic cell were found, this is called a positive margin. And this have a poor prognosis. And if within that zone of the normal tissue, there was no dysplastic cells, this is called a negative margin, which have a better prognosis. Perineural invasion is associated with poor prognosis. I'm going to discuss it in the next slide. Vascular invasion also associated with poor prognosis, and the spread to lymph node is included within the staging and grading, and the location. The importance of the location, because some tumors have better prognosis because of their location. So for example, if you have lip tumor, it have a better prognosis than the tongue or intraoral tumors, as we said, because there is easy spread of infection or of tumors intraorally from the tongue specifically. So this is a histological picture of our case, and perineural invasion is a pathological finding that is often associated with head and neck cancer. In perineural invasion, this is the nerve. Then the tumor cells are infiltrating the nerve. And many theories have suggested at the beginning, earlier they used to think that the presence of these cells is just because of the metastasis, which have been proven to be wrong. And modern studies have shown that the perineural invasion is a deliberate molecularly mediated interaction between the nerve cells and the tumor cells. And let's not confuse it with the perineural spread. In the perineural spread, the tumor cells uses the nerve to spread from the primary tumor into another side. This is a different story from the perineural invasion, which is an interaction between the tumor cells and the nerve cells and the nerve. Okay, so looking at our case, the patient is young. He's only 38 years old. He does not smoke. He never smoked. He doesn't consume alcohol that much, only 1 glass every 2 to 3 months. And P16 has turned negative. So all of that leaves us with the only risk factor that we have is the inflammatory bowel disease, which is the ulcerative colitis he was diagnosed with in 2013. So the inflammatory bowel disease is a term that is given for 2 diseases, as we said earlier, ulcerative colitis and Crohn's disease. It is characterized by a chronic inflammation that results from host microbial interaction in genetic susceptible individuals. It results in a chronic inflammatory environment in the oral cavity, stomach, small intestine, large intestine, esophagus. So the epidemiology of oral cancer in inflammatory bowel disease is currently unknown. And there is few indirect informations that can be extracted from large coherent study. It could be also possible that in the past cancers, oral cancers in inflammatory bowel disease were included within the head and neck cancers. And thus this is overshadowing the exact magnitude of the problem. So the possible mechanisms of carcinogenesis in ulcerative colitis. In ulcerative colitis, there's 2 possible mechanisms or 2 theories of pathogenesis of the cancer. The primary mechanism is because the nature of the disease, there is repeated flare-ups of inflammation of the disease. And as we explained earlier, the inflammation it provide these tumors with a rich environment that is rich in nutrients that the tumor need, that help it to feed. And the repeated flare-ups of inflammation can also contribute to the genomic instability, to the epigenetic modifications and induction of the cancer cell proliferation, as we explained earlier. So all of that can result in the oncogenic insults to the epithelium. The secondary mechanism is mainly because of the chronic use of the immune suppressive drugs. And what the immune suppressive drug do is that it weakens the immunity. And when it weakens the immunity, it makes it less able to detect the tumor cell to destroy it. And this will result in enabling the carcinogenic cells to evade the immune response. So that's why, because a significant number of patients with inflammatory bowel disease are receiving immunosuppressant and chronic immunosuppressant, they should be considered as a high risk factor for cancer development. So looking at the primary mechanism in which the repeated flare-ups of inflammation, as we said in ulcerative colitis, this is represented by oxidative DNA damage, which can result in aneuploidy, which is a loss of or gain of chromosomes, P53 mutation, inhibition of oncosuppressor genes, and all of these mutations can result in the low-grade dysplasia. The low-grade dysplasia can then transform into high-grade dysplasia, which will result in cancer. The second mechanism, as we said, the immunosuppressive medication, right? So there is the cancer immunoediting process in which the host system shapes the fate of the cancer tumors into 3 fates. So if we have a competent immune system, then it's able to eliminate and destroy all the cancer cells, and this will result in elimination. So sometimes an occasional tumor cells can manage to survive the immunity. And in this case, this will result in equilibrium between the immunity and the cancer. And in the third phase, the cancer can overcome the immunity and can escape the immune response. This will result in cancer formation, escape of cancer, and metastasis. So one important information that we need to know is the thiopurines. This is specifically the medication our patient is using. So now we already understood the role of the immunosuppressive and how the immunosuppression causes the cancer. There is also an important role that these thiopurines play because they have an inherent mutagenic potential, because they can cause mutation in a tumor suppressor gene known as PTCH, protein patched homolog. So this gene acts as a receptor for the Hitchcock pathway. What is the Hitchcock pathway? This is a pathway that is active during the embryogenesis and the organs formation. So once the infants are developing and once our organs are developing, this Hitchcock pathway is very active. But after completion of growth and of the organs formation, the Hitchcock pathway is inactive. So mutation in the PTCH and some tumors have the ability to reactivate this pathway, and they use it so the tumor itself can grow and sustain this proliferative signaling through this pathway. So this should also be considered. So treatment of oral cancer in the inflammatory bowel disease, surgery, the normal general treatment approaches like the surgery, radiotherapy, and adjunctive systemic chemotherapy. But what is also important to add in these patients is the modification of the immunosuppression, because as we explained now, the role of the immunosuppressive medications in the development of the cancer. So the prognosis, as in any other patient, the prognosis depends on multiple factors like the location, the size, the lymph node involvement, and the same factors that we have discussed earlier in the prognostic features. So our patient updates: the patient was diagnosed with stage 2 cancer. The tumor is larger than 2 centimeters, but not more than 4 centimeters. He was admitted to the hospital and nasopharyngeal endoscopy was performed. There is no lymph node involvement, and surgical removal of the lesion was performed on the 26th of July. Removal of the lymph node of the neck was also performed prophylactically, and further radiotherapy treatment was carried out on the 18th of August. So in conclusion, oral cancer in patients with inflammatory bowel disease represent a reality, as they have already been reported for years now. Patients with inflammatory bowel disease belong to the high-risk group of developing oral cancer, and physician awareness about inflammatory bowel disease and the patient awareness about the modifiable risk factor is a cornerstone for prevention of oral cancer. Oral screening should be performed for all patients, and especially patients with inflammatory bowel disease who are taking immunosuppressive medication. So thank you everyone for being here. And here's my references.
Thank you, Dr. Mozn. Thank you. I really enjoyed your seminar this evening. It is a really interesting case. Thank you so much for all the effort that you put in there.
Thank you. Thanks.
Dr. Mozn, I see I'm just going to give our colleagues some time if they want to ask questions. But I've got a question. Often our colleagues are in clinics, they're not in a periodontist setting like ourselves that are confident in doing incisional biopsies. They do not necessarily know if a site perhaps warrants a biopsy. I know that you refer to brush biopsy techniques. So my question is there a specific brush that you can recommend? And if so, why and how accurate is it? Can a definitive diagnosis be made with that?
Okay, so there is a variety of brushes available. There is some we use at department, and there is the CDX chairside brush that you can use. So these brushes, what is As I said in my presentation, we were very scared from the lingual artery because it's running very close to the lesion. Then in such a scenario, such a situation, a non-invasive technique, or even if you do not like, because the pre-malignant lesions are appearing intraorally as multiple lesions, and you don't want to put the patients through the agony and the pain of the biopsy itself. Then a use of this brush where you go through all the epithelial layer and remove, and as I said, you try your best to scrape the brush according to the epithelium until you see some bleeding point to tell you that you already reached that connective tissue. Then you can use that and send it to the lab where they come up with the results. So it's a much better non-invasive technique where you can use to avoid biopsy.
Awesome, thank you. And I can maybe just add on to that. I know that it is a question that might be asked is how easily available is it? And you can get it and source from PathCare labs, the private labs, AMPath, or the National Health Laboratory labs. You must just request specifically for the oral CDX brush, then they will deliver that to you. Then the other question I also have is, I understand that your patient, after they've done the excision of the tumor and they removed the cervical lymph nodes, they also did radiation therapy. Do you, in the department, or do you guys have some protocol? How do you manage a patient with radiation therapy that is on being treated with that? Because I suspect that there's xerostomia, high risk for caries. What's the protocol?
Yes, and for those patients, we specifically...
Okay, I found this on the web. For their xerostomia, high risk for caries. What's the practical?
So for those patients, we try to always manage all the dental problems before they start the radiotherapy because of the complication you just mentioned. The chance for the osteoradionecrosis is very high also for those patients. So if there's extractions or fillings or anything that need to be done, it's done before the surgery. And this is actually what happened to my patient, where he had an appointment 2 weeks before the start date of the radiotherapy. They did his filling, they did extraction of the wisdom teeth, and everything was done before the surgery to avoid all the complications.
Okay, awesome. Thank you. Would you follow up such a patient during treatment with radiation therapy to maybe manage how
Yes, we do follow up these patients, and specifically because of the xerostomia that is associated with the radiotherapy, with the increased caries rate, the discomfort they have, and also periodontal disease is common. So for those patients, we do follow up. And my last follow-up with the patient was he have an appointment with me in 2 weeks from now. So yeah. We'll take an updated pictures and just...
Oops. There we go.
Yeah, sorry.
No, don't worry.
You can hear me, but you can't see me, right?
And we can see you.
Okay.
Thank you, Doctor. I really enjoyed tonight's seminar. I can see that you put a lot of effort into your presentation, and it was really well researched and really a thorough presentation. And I really have to thank you for all the hard work.
Thank you, Dr. Stanley.
Okay, dear colleagues, I don't see any further questions. So from my side, thank you for joining us this evening, and please remember the upcoming webinars for the 16th and the 21st. Thank you.
Thank you.